This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Shuvro Roy from the University of Washington, and welcome to today's Neurology podcast. Today, I'm pleased to be joined by Marisa McGinley, an assistant professor of neurology at the Cleveland Clinic, who is here to discuss her article published in Neurology Clinical Practice titled Disparities in Utilization of Outpatient Telemedicine in Neurologic Care. Marisa, thanks for joining us today.
Oh, happy to be here.
Why don't we just get right into it? Can you take us through the key findings of your study on telemedicine utilization in neurology?
Everyone is really familiar with telemedicine now. The pandemic obviously made it part of our daily lives, so seeing patients. And so with this study, we really wanted to look at the use of telemedicine for neurologic conditions, but really broadly, because we wanted to see how the pandemic has really shaped our use of this. And so what we did in this study is that at the Cleveland Clinic, we looked at the use of all of our visit types, starting in 2019 all the way through July of 2022. And we picked this time frame because we wanted to understand pre-pandemic the use of telemedicine, and then we wanted to understand the early phase of the pandemic and that really high utilization, and then more the new normal, right, of what we're doing with telemedicine now in 2021, 2022. And really the focus was at understanding different groups of individuals and how they were using telemedicine. I think prior to the pandemic, there was definitely concerns about disparities in the use of telemedicine, partly because regulatory payer restrictions. It wasn't accessible to everyone because a lot of the times it was out of pocket. So at Cleveland Clinic, we have a long-standing telemedicine program that we've used in neurology since 2014, but coverage was pretty sparse. And so we really found that it wasn't utilized broadly. What we did is, so we saw that pre-pandemic, and then we looked at the early pandemic period where obviously there were huge lifts in the restrictions. And so, everyone really had the opportunity to do telemedicine visits. And obviously as clinicians, we were pushed to use them even more because a lot of the stay-at-home orders. And so in the study, we looked at that and we really want to understand how that changed utilization by underrepresented populations. And so what we found was that there was really a low utilization of telemedicine for neurologic conditions prior to the pandemic. We saw a huge uptick in utilization in that early pandemic period, which was great. And it was across the board for all groups of individuals. After that initial couple of months of the pandemic, we still saw some reassuring signs that utilization was much higher than pre-pandemic levels for teleneurology, but it was already starting to wane a little bit, which I think we've all experienced in our practice. And there were persistent disparities. So there were definitely key underrepresented groups, including our Black populations, Hispanic populations, those from areas of higher deprivation, those with non-private insurance and non-English preferred language, that we really saw, although they were utilizing telemedicine a lot more than prior to the pandemic, still were not using it to the same degree as their more represented counterparts.
We obviously know, I feel like there's a lot of literature on the use of telemedicine early in the pandemic, certainly ramped up out of necessity, but especially as we've seen this fluctuation even in just restrictions between states and telemedicine utilization, payer restrictions. Thankfully, it seems like every year we're able to at least get it approved such that telemedicine reimbursement is equivalent to an in-person appointment. But there are these fluctuations, and being able to see how this evolved over time as we shifted away from those stay-at-home orders is, I think, really one of the true strengths of this paper, and especially the way you organized it in these different phases. What motivated you to specifically investigate disparities in telemedicine use?
We already had a track record of using a lot of telemedicine before the pandemic, and I think in my practice, I saw it wasn't utilized by everyone that I saw. And so I felt like, at least for me and others that practice around me, my telemedicine population did not look like my just general clinic population. And I really wanted to say, this is my general observation. What's the reality? What does the data show? Who's utilizing this? And where are the gaps in use. And also in the broader context of healthcare, right? We know that there are populations that experience health disparities. And I think one of those disparities of concern is access to healthcare. And there's a lot of touting about telemedicine being this, oh, it's going to help improve access to care. And I am absolutely a proponent of telemedicine, love it. I think it has that potential. But I think for telemedicine to really realize that potential, we need to understand what, facilitates the use of telemedicine, what barriers are there. And I think that really starts with understanding how patients are utilizing it now. And I think that was really the spirit of seeing, hey, I don't feel like there's equal utilization. I really want to understand this a little bit better. And really with the really long-term goal, right, of we want this tool to help improve access to our neurologic care. And however we can do that, identifying these barriers of use, how can we overcome that? So this really becomes a tool to help with health equity concerns.
Fantastic. And let's get into some of those specific disparities you identified. And in this study, you highlight persistent disparities really across the timeline in telemedicine use amongst Black patients, Hispanic patients, and patients of lower socioeconomic groups. What are some of the specific barriers there that these groups face in accessing telemedicine for neurologic care?
The study didn't look at those barriers in particular. We have this observation, right, that it's not utilized by these important groups as much. So a lot of the potential concerns or barriers there are from other literature, I think. And so I think this is really, like I said, a stepping stone. And so I think some of it is around device access and broadband, right? That's a consistent concern that's brought up about telemedicine. And so I think that I highlight in our discussion here that obviously broadband access disproportionately affects underrepresented populations, specifically Black and Hispanic households tend to have less broadband access than our white predominant households. And so I think that's a concern. And there's a lot of work really at the national level to think about broadband access as an important social determinant health. It's not necessarily one of the hallmarks that we think about measuring, but I think when it comes to telehealth access, that is definitely a cornerstone there. And then I think along with the broadband access goes with devices too. We think about everyone having a device. Pretty much every patient that comes into your office, you think, oh yes, they have a smartphone, they have some device that they're capable of doing a video visit, but that is still not universal. So I think that assumption around device availability is a concern. It's also a functioning device too, and a consistent access to a device. So I think that device access and broadband access are definitely things that could be contributing to the disparities that we saw here. That also dovetails with the area deprivation index. So obviously these are more socioeconomically disadvantaged populations for utilizing telehealth. Less it is expensive to maintain internet access and have devices consistently. So I think these are important factors. And all of the visits that we did here were in people's own homes or in their own whatever setting. So it was using their own devices. There was no provided devices for this. So I think that's a concern. And then I think outside of those infrastructure questions, there's also just patient preference. We really didn't look at that here, right? And I think that another thing that's speaking to this is that, yes, there's disparities, but there's also a preference of how patients consume and get their health care. And I think that as clinicians, that's a really important thing. When we're sitting down with patients, not being so prescriptive about how the visits need to get done, whether that's in person or virtual through telemedicine. Really, with this work and everything that I've done, we want telemedicine to be another tool, like I said, to address disparities, improve access, but it's not the answer for everyone. And I think that trying to disentangle what are barriers people have of, I want to do it, but I can't do it, things like devices and broadband versus I don't want to do it that way. I feel my healthcare, I have a better connection, or with the symptoms or concerns that I have, like I want that in-person evaluation, whether that's from the patient or even us as clinicians, right? We can't say that every situation is best served by a telemedicine visit. So I think that some of that might be those preferences are different across different communities, different cultures. And I think we need to understand that better. There was some work done that I alluded to, and I don't think it was Neurology, but in some rural Black communities, specifically talking about that and that connection with their clinicians. There's also a digital literacy component too. So there's a discomfort maybe with doing these visits, but some of it's around the understanding of the process and also what can be done at the visits and the logistics that I think is another barrier that needs to be more consistently addressed. So we start to, again, disentangle what's a barrier and what's a preference from our patients.
You touched on something that was pretty surprising to me from reading through this paper. And oftentimes when it comes to the telemedicine literature, we're so focused on the idea of the digital divide. And you certainly touched on that with regards to device utilization, broadband access. One of the things that I think has been a major concern with the uptake of telemedicine utilization is the use of it in rural communities. And in this case, actually, you found that there was equal utilization amongst rural and urban populations. What do you think the implications are for that in terms of future telemedicine policy and utilization?
We've obviously focused on the less utilization by other populations that's a concern, but I think the fact that our rural population utilized telemedicine just as much as our urban population was really encouraging. And I think it actually does go along with a lot of the literature that's been published. There were mixed results of concern that there was less utilization, then others said that it was equal. So I think there's actually a growing literature to support that our rural communities are able and interested in using telemedicine. And to me, that's great, because when we look at other concerns for access, really a lot of it is where are neurologists? And we had actually published another study this last year in Neurology about geographic disparities of where neurologists are practicing. And disproportionately, rural communities do not have good access to neurologists. This is obviously an area of concern. And although we would love to say many of us could go out to rural communities, or can we incentivize or get more clinicians to be practicing in rural communities, I think the reality is that's not going to meet the access need, right? We may be able to expand access and have more rural community presence, but I think telemedicine really has a hope to bring a lot of these services to rural communities. I think the other really important thing is not only neurology in general services to rural communities, but also subspecialty care. I think there's also, in addition to a growing movement of centralizing where neurologists are practicing, we also see a subspecialty trend, right? I think there was another study published that 90% of neurology trainees plan to subspecialize or do a fellowship that they're going to subspecialize in. And that means that so much care ends up getting compartmentalized for patients. So they may have an amazing neurologist that they're working with in community, but there's still a desire of like I want a one-time opinion with this epileptologist or with this MS specialist, just to say, hey, anything that we do differently here. And I think telemedicine is a great opportunity to bring those services to patients where they are. Because I think I have a really strong sense that we should not make patients move just for healthcare. And it's not realistic to have patients constantly travel to larger centers for healthcare. I think that is a huge barrier. Some patients will figure out and do it, the ones that have the means to do that, and other people will say, I'll just go without. And so I think that is a major problem and a disparity that really needs to be addressed. And I think this work really highlighted the potential of telemedicine to really bring that neurologic care to patients in rural communities that right now are underserved for sure.
What I want to ask you is, moving forward for those of us who utilize telemedicine quite often in our practices, what strategies or policies would you recommend to help reduce these disparities in telemedicine utilization?
It's a little bit of a hard one in the sense that we still don't fully understand, like I said, the difference between preference and barriers. So I think one thing that is a low-hanging fruit is having a conversation with patients about, are you comfortable with doing this? Like, I would think doing a telemedicine visit is a good idea. How do you feel about that? You'll have patients say, of course, yeah, no problem. And then it gets scheduled that way. But I really open up, and I think it's good for patients to say, no, I don't want to. And then you follow it up and you say, why? I think we need to understand better in our practice. Is it because you don't want it, which is fine, right? Like we can absolutely do things in person. Or is it because you're worried about, I don't understand how to get on my patient portal to do the visit, right? Or no one's ever shown me that, or I'm locked out of it, or things like that we can address with like our IT departments that are pretty easy. So I think one, as clinicians, just truly asking patients when you think it's appropriate to do something via telemedicine, because you're just going to follow up results. It's going to be a touch point about symptom management, something that you think your in-person evaluation isn't going to change much. We should offer it just because it gives the patient more options for getting that care. And then if they decline it, just try to ask one follow-up question about, well, why? See if it's something to address. So I think that's a simple thing that we have control of as neurologists. I think the other things are bigger IT infrastructure things. So I alluded to in the discussion, there was an interesting study done in the oncology world about trying to pre-identify patients that had potential barriers. And it was things that made sense. Like they didn't already have a portal like account set up, right? And that's how we all do most of our telemedicine visits. Or they didn't have a social security number, or they didn't have English wasn't their preferred language. So trying to pre-identify some of the things that we're highlighting here as potential concerns, right? Barriers, like how do we in our hospital systems build in some little flags, right? That we can identify, oh, this patient might not connect if they're scheduled virtually and we should follow up with them in another manner. So I think there's a need, and that speaks to the idea of understanding almost a new dimension of a social determinant of health, right? We think a lot about, what does their job look like? What's their housing security? But like, what is their technology access? What's their experience there? So I think thinking about larger EHR systems, we have the option to think about more, how do we red flag this, right? So that maybe don't think about scheduling it via telemedicine, or we address the barriers that might exist so that you don't schedule these things that aren't getting done or aren't possible for patients to do. So I think there's a need to do that from like a system-wide perspective. So I think there's what we can do as our individual clinicians, what we have control of with our patient communication, our hospital systems and our EHR having more tools to flag these potential disparities. And then I think there's larger policies that I think we can advocate as neurologists, things like affordable acts for broadband access, right? So there's a lot of those types of acts in Congress that would allow for more widespread access to internet services that I think would facilitate these. I think when we think about other regulatory things with parity of visits, making sure these are continue to be covered. Because again, I think a lot of what we saw with the increased utilization is patients had the same copays, right? So of course, they're going to be able to do them better. We continue to have to advocate for that and make sure that we don't start widening the gap again because of disparate coverage of these services. And then also, as you alluded to, some of the regulatory restrictions when it comes to licensing, right? I think there's still a need of, I may really want to provide these services to a patient that lives an hour away, but it happens to be in a different state. And so now I have to get a new state license, and that is time consuming. And again, some of us are able to do that. We have good infrastructure to do that with our health systems, but it's not necessarily possible in all capacities. So I think, again, as clinicians, advocating for thinking about some smarter regulatory moves that just allow us to take care of patients that need care and be able to use this tool more effectively. So I think it's going to have to be a multi-level approach, but I do think there's things that we can do here and now. Again, make sure patients get to use this tool if they want to.
So one of the interesting signals that you did identify in this study, and it was with a small proportion of the patients, I think it was something around 2%. But one of the strengths of having such a large sample is that it did still seem to hold up. And certainly, even in my practice, I feel like it's the case. You noted that non-English speaking patients, and then maybe even English as second language patients, were less likely to complete telemedicine appointments. You've just spoken about all of these infrastructure changes that we can make at even a federal level, but also at an institutional level to help improve access. How do you envision integrating language or cultural aspects into telemedicine platforms to improve access for these non-English speaking populations?
Our catchment area in Ohio, we have a smaller proportion of individuals that at least don't report English as their non-preferred language within our health system. So I do think that it's really important. There are many other places in the United States that have much higher proportions. And I also highlight, I think it's almost like 8% of the US population in the last census thing that I looked at had a non-English preferred language. So it's a huge part of our population that I think needs to be addressed. And in our system, our electronic health record, we do identify individuals that indicate that English isn't their preferred language or what their preferred language is. And we try to then assign an interpreter before that with the telemedicine. I think probably all healthcare systems kind of admit that's not a perfect system. So I think there's some need to better do that. I think it's also patients don't always realizes that's happening in the background. So there's some barriers because they're just not sure about what the interpreter services are going to be available. I think that even happens with in-person care, right? There's just a concern about when you get to the healthcare facility, there's a gap, right, of that immediate interpreter services. There's some concern, there's some discontent. So I think the more streamlined integration of interpreter services is going to be important. And we have that capability. And I would say it's another advance of technology, because a lot of our interpreter services are digitally available, but it's not just a in-person interpreter. And so we have the ability to connect with a lot of different interpreters, various languages. So I think that's a potential. Another major barrier is the instructions. We obviously for our visits had translations for English and Spanish, but I think that even likely the Spanish translations, and then we have a deficit of other translations consistently. If patients don't understand how to get onto the visit, that's going to be a problem. It's going to be a huge barrier, or they're going to think they're connected when they've just signed into their portal. They don't realize the next step just because the instructions aren't clear. And so I think however we need to do the instructions plus streamlining interpreter services, I think is going to be really important. It also is going to be a little bit of a more widespread, I don't know if the word is marketing or something, again, more information to those populations, right? So they feel comfortable that, hey, we acknowledge this is maybe you have another step to do than our English speaking patients, but we want to make this work for you. And getting the feedback of again, what's the problem? What's the barrier for you? How do we address that? Is it that you didn't understand the instructions? Is it that you really needed the interpreter even to help you pre-visit with this? So I think we need to engage populations that are not English preferred language and understand what is the gap and the steps to doing these visits, because that is I think a universal finding in most of the other studies that I looked at too. And like I said, it's only a growing population in the US. And so again, if we expect patients to only get care in person, they are not going to get all the care they need at this point, right? Because telemedicine has become an integral part of how we deliver care. And so as we are advancing that, which is great, we need to make sure that populations such as our non-English preferred language population are not left behind, now missing out on more care because we're recommending visit types that they can't practically do. So I would say interpreter services being more seamlessly integrated, and then having instructions that are clearer for these populations in their preferred language is going to be really crucial. And again, still it's at the visits when we have in-person visits, identifying with our patients in the office, how do we make this work for you? That individualized approach so that we just understand how we can use this tool for everybody.
Absolutely. I think that's maybe even its own study of looking at what is driving that. And is it as simple as a lack of transparency or understanding of the interpreter services available? Is it adjusting that model of generally how we have an online interpreter joining for the appointment? Or is it something else? Marisa, I'm going to close with maybe a big question, maybe a bit of an unfair question, but I feel like you're able to uniquely comment, given that you've actually looked at data and observed the evolution of telemedicine over these 3 different time periods, basically over the course of the pandemic and beyond. How do you see the role of telemedicine evolving in neurology as we move forward into what has become this new normal, as you had previously mentioned?
Well, one, it's here to stay, which is great news. I think that I had a concern, right, that there was going to be this boom use, and then for some reason, payers or regulatory things were going to really diminish its use. We did obviously see some reversion in our new normal phase of this study. Some concerns there, but some of that is also just speaking to the other individual population barriers and preferences like we've been talking about in this interview. So I think, first of all, it's here to stay. The question is that we had this great innovative moment in healthcare, right, where we were all pushed to figure out how do we integrate this at a large scale. And we have now. And now hospital systems, smaller places have great infrastructure, right? And so I think one of the major barriers pre-pandemic is so many places didn't have the infrastructure. So we have that now. And now that we have it in, I would say, an ad hoc way, right? Most of us in practice use it here, use it there. What I really see for neurology and healthcare in general is now we have to take this tool and say, how do we make healthcare better with it? Right now, it's hopefully improving access sometimes, giving some more preferences to patients, reducing some barriers. But to me, that's not enough, right? We have this great tool. How do we think about different innovative partnerships between different clinicians, different healthcare systems, where we share resources and we really, like I alluded to with the rural populations, bring care to where people are when they need it. And I think that telemedicine, teleneurology is uniquely positioned to really bring that care to people. But it really, I think, is going to require a very systematic evaluation of clear care models that are using it, right? Right now, it's just a here and there, we throw in telemedicine visits. But how do we come up with maybe completely virtual models, right? How do we think about providing completely virtual care to some patients in communities, working with other providers, maybe locally? How do we use this as neurologists to partner more with our internists or our primary care physicians that are in communities that they don't necessarily have access to us? So to me, I think that there's a need to think about communities and populations that already have problems with accessing neurologic care, and how do we develop healthcare models using telemedicine to really meet that need. So I think that it's here to stay, but it's going to take a lot of targeted approaches to develop sustainable models for it. And like I said at the end of this paper is we didn't focus on if telemedicine truly improves access. So there's a need to really show that, right? That's the goal. I want to give more options to patients that are already accessing the healthcare system for sure, right? We want to take better care of the people we already have. But I think as a field, we really want to get more care to people that aren't even in our system, people that aren't seeing a neurologist, that have a neurologic condition. How do we do that in a way that's sustainable for us as clinicians in the healthcare system, but really advances access to our neurologic care? So I'm very hopeful that's possible, but I think it's going to take a lot of partnerships between neurologists and other disciplines to really think about what those models look like.
Absolutely. Marisa, thank you so much for your time. Again, I would direct everyone to read the article, Disparities and Utilization of Outpatient Telemedicine for Neurologic Care, published in Neurology Clinical Practice. That's today's Neurology podcast. Thanks for tuning in.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn